So the first one is by Dr. Puja Maitra, Pediatric Retinal Disorders, Interesting Cases.
So good afternoon to this post-lunch session. I'll be sharing some interesting cases, and because it's the pearls in pediatrics, I thought that I'm going to share some pearls that I gathered along my pediatric retina journey. So I've divided into few sections and what I have learned from these cases. So let's start with the first case of a preterm child with gestational age of 32 weeks and birth weight of 1860. And when we saw the child was can you dim these lights? So the child was 34 weeks at that time.
You can't put off this light.
So don't they know the session is going on? Because they can't see, na, with just so much of light. No, those.
No, we can see
see
here.
it. These people can't see.
Okay, I think let us.
Okay,
Move
let
on.
me continue. So
If it is not going
I'll
to
just
change.
describe the findings. So both I had severe retinal ischemia with sclerosed vessel and total shallow exudative RD. And what we did it was injected ranibizumab. Now, question is this ROP? So yes, this is ROP, and we were not the first people to see it. It has been seen earlier by the LBP group and reported this kind of a severe exudative ROP. But it was first described by the Shankar Netralaya group, where they actually told the mechanism to be because of fibrinogen leakage into the retina that causes an inflammatory response, and that causes leukocyte infiltration and subsequent exudative retinal detachment. So 1 week later, after the intravitreal, the exudative RD improved, and at the last follow-up, both eyes were vascularized up to the zone 2 anterior. So this is the second case of an 11-year-old female child who came basically with squint and was sent for fundus evaluation. The left eye showed a retinochoroidal coloboma. Now the right eye, there's a mistake in my presentation. Sorry for that. The right eye had optic disc pit, exudation with telangiectatic vessels temporally and in the ITQ. And there was a vasoproliferative tumor-like lesion. And also the child had retinochoroidal coloboma. So the diagnosis was Coats disease with secondary vasoproliferative tumor with optic disc pit and RC coloboma, and for that we did green laser. So we do find many pathologies at once. So the first pearl was be prepared for the atypical, because pediatric retina is full of surprises. Coming to the section 2, so this was a child who was a baby, 5-month-old with squint and referred for prominent eyeball to rule out congenital glaucoma. Now, when we looked into the details of it, not just there was tessellated fundus, but periphery had thinned out areas, and there was opalescent vitreous strands. The other eye, if you look at it, it just looked like there was tortuosity of vessels, but if you look closely, there was a shallow retinal detachment. So we did rule out congenital glaucoma and went ahead with a belt buckling surgery. And post-operatively, once the retina attached, we did a 360-degree barrage laser. Now, interestingly, this child also had peripheral avascular retina, which was revealed on RETCAM fundus fluorescent angiogram. And because of these atypical features, we did a genetic testing. We suggested clinical exome sequencing, and we found a mutation in the COL18A1 gene, which was a pathogenic variant suggestive of no-block syndrome. And the same mutation was found in carrier state in both the parents. So what is no-block syndrome? It's a triad of high myopia, vitreoretinal degeneration with occipital defects. Now, what I learned from this case is pediatric RDs can be extremely shallow and subtle. Underlying syndromic associations must be suspected when the RD presents at a very young age. Genetic testing holds the key in diagnosis of symptoms and must be considered when the family is extremely inclined towards knowing a definitive diagnosis. So this is another case which is actually referred for ROP screening, and the referral letter mentions sclerosed vessels. What we actually saw was lipemia retinalis, and I advised the lipid profile. The triglycerides came out to be 1898, very high, and we started the child on formula feeds, and after that the lipemia sort of improved. This is another child, again came for ROP screening, and had a syndromic phasis, and also was a known case of corpus callosum agenesis. So right eye had tessellated background with hypoplastic disc. And there was some fibrosis in the periphery and peripheral avascular retina, which was well seen on the fundus angiogram. Left eye had a folded retina over the disc, and there was no significant family history. So coming to corpus callosum agenesis, it is actually the most frequent brain anomaly in children. It can have a non-syndromic and a syndromic variant. The non-syndromic one is associated with poor vision, refractive error, and squint, but the syndromic one is associated with a lot of fundus features, which Aicardi syndrome is something we all know, but it's also associated with Walker-Warburg syndrome, which is probably the most diagnosis in our case, and even FEVR has been described with corpus callosum agenesis. So fundus evaluation is a must for syndromic patients. So pearl number 2 is look beyond the eye for syndromic and systemic associations. Okay, section 3, this is a case of stage 4B retinal detachment. We had a tractional and an exudative component with peripheral fibrosis with vascularly active component. So this case was managed by lensectomy and vitrectomy. And after 1 week, there was some, the fluid had settled to some extent, and after 3 months, we had a good anatomical outcome. So why I showed the first case is in perspective of the second case, in which we saw tractional schisis at the macula with a peripheral fibrosis. And in this case, we did not do vitrectomy. We only did a belt buckle and external approach along with laser. And at 2 weeks, we had a resolution of the schisis, and at 2 months, we had flattening of the posterior pole. Okay. In opposition to this, we had another stage 4B detachment, again tractional and exudative component with peripheral fibrosis and vascularly active component. Now this child had multiple systemic issues, and we were waiting very long for the general anesthesia fitness. In the meantime, we injected intravitreal anti-VEGF, and this is how the child was pre anti-VEGF, and this is how it was post anti-VEGF. We had a good settling of the macula, although there was some peripheral residual traction, but because of the systemic nature of the child, we decided to observe this child. So third pearl is less is more, and perfect is the enemy of good, whether when it comes to pediatric retinal surgery. So these are my pearls, and I have to thank my mentors from whom I have gathered these pearls in my experience. Thank you so much.